Howdy, y'all. It's Dr. Jeff Jarvis and Nova, my daughter's cat. We have a quick, don't hit the mic, cat. We have a quick, say hi to everybody. I have a quick performance improvement module. We need to make a change in what we're doing in cardiac arrest. We don't have a whole lot of time to push this out, so we got to do it quickly. Here's the problem. We have a shortage of epinephrine 1 to 10,000 prefilled syringes, the Bristagets, the Papa Top, Johnny, and Roy things, the things we just push into cardiac arrest patients. We can't get enough of the prefilled syringes to meet our needs. We're going to run out. Here's what we're going to do. This is the bottom line right up front. In adults, and adults only. So we're only talking about adults. I cannot stress this enough. Pediatrics, keep treating it the way we always have. Straight pals. In traumatic cardiac arrest, so traumatic circulatory arrest, this doesn't apply since we shouldn't be given epinephrine at all, right? No epinephrine in trauma, despite the fact that we seem to keep giving epinephrine in trauma. So we're only talking about medical arrest. What are we going to do? We're going to give that first milligram of epinephrine, and then we're done. One and done. No more epi. That's it. Well, Dr. Jarvis, what if they get pulses and then lose patient pulses again? We haven't given this cardiac arrest epi. It's the same patient. 1 milligram, then we're done. No more, even if they get ROSC and then lose pulses. So that's what we're going to do. It's going to conserve our prefilled syringes. It is going to allow us to use those prefilled syringes for the cases we need it most. Pediatric arrest, where we don't need to be mucking around trying to dilute out epinephrine to get to kids in a really high stress situation. So we need it for the kids. We need it to get the drug into patients as soon as possible. And we need it to mix push dose epi, because the last thing we need to do is take the 1 to 1,000, dilute it to 1 to 10,000, and then dilute it to 1 to 100,000, because I guarantee we're going to mess that up. Forget to do it twice, and we're going to give 100 mics instead of 10 to a patient who is not in cardiac arrest. That would be bad. None of us want to do that. So what are we doing? 1 milligram and done. 1 and done. That's it. The rationale for this, here's what we know about epinephrine from the literature. The best trial we have on this is Paramedic 2. Large randomized control trial, very, very well done. Patients in non-traumatic cardiac arrest got randomized to 1 milligram of epinephrine, 1 to 10,000 every 35 minutes, just like ACLS says, or placebo. And what they found with thousands of patients in the trial is that the group that got epinephrine had 0.8% increased survival at 30 days, with no difference in neurologically intact survival over the entire group. They also saw way more ROSC with epinephrine. It's not surprising. I think we know by now, you give epi, you get ROSC. The more epi you give, the more ROSC you get. ROSC isn't what patients care about. And how do we know this? Well, we asked them, and they say, that's not what we care about. We want neurologically intact survival. Okay, so what's the harm? The harm, that trial showed that if you look at patients who survived and ask what their rate of neurologic devastation is, that's the thing patients fear most, is surviving but having neurologic devastation. Twice the rate of neurologic devastation among survivors in the epinephrine group. Epi is doing something, but it's not what we want. We can't get rid of epi completely right now because it is doing something. But the thing we clearly know is that it's not doing what we want. So what about limited epi? The best evidence we have for this is from North Carolina, where they did a before and after study in 5 county-wide EMS systems in North Carolina. Before, they were doing straight ACLS, 1 milligram every 3 to 5 minutes. After, they gave 1 milligram and were done. The title of the paper was 1 and done. Exactly what we're proposing. What did they find? Well, there was much less ROSC. Not surprising. We're going to see much less ROSC too. We can predict that. But they saw no difference in overall survival or neurologically intact survival. That's interesting. Less ROSC, no difference in survival. They're still getting epi, but remember, they're just getting one. Then they did a secondary analysis where they said, well, what about in different age groups? In patients under 65, exactly like the overall, less ROSC, but no difference in survival or neurologically intact survival. But then they looked at patients who were 65 years and older. Again, they saw less ROSC, but now they saw more survival and more neurologically intact survival in the groups that got just the single dose versus the multiple doses. That's not a randomized trial. It's not the world's best evidence, but it's the best evidence that we have. We have a shortage that we can't do anything about. We would love to get more epinephrine, but as Mick and Keith will tell you, sometimes you just can't get what you want. You can ask, but you can't always get it. We can't get it. We got to conserve it. This is how we're going to do it. So to emphasize this again, last point, here's the key takeaway. This is what we're changing. Pediatric arrest, keep doing what you're doing. Push dose epi, keep doing what you're doing. Adult non-traumatic arrest, 1 milligram of epi for all patients, and then you're done. So we're basically eliminating the 2 milligram infusions in non-shockable rhythms. Should be simpler, should conserve epi, should allow for cognitive offloading. You get to think about other things. Good compressions, good airway management, good defibrillation. One less thing to worry about. So that's it. I hope this was helpful information for you. I'm sorry to have to change the protocol at such short notice, but this is the world we live in. We like to think we practice evidence-based medicine. We really practice availability-based medicine. And the epi we want is not available. Thank y'all for everything you do. Have a great day. Take care.